Thank you for watching the World Community Magazine's Hour of Power Live on Facebook with your hosts Edwin McQueen and April Garner.
Good evening, Sister Joella. How are you?
Oh, wonderful, Sister April, and it's a blessing to see you this evening. How are you doing?
I'm doing well, and thank you all for joining us for the Whittemore Community, or I should say World Whittemore Community Magazine Live. It's been a long time since I've been actually on the screen. Brother Edward usually opens it up every Monday evening at this time, but it is a pleasure to be here, and it's certainly wonderful to see you, Sister Joella.
Likewise, my beloved. You're so beautiful this evening in your beautiful colors, which represent so many things there.
Yes, absolutely. We want to get into it and go ahead and thank our special guest for being here, Dr. Regina Hampton.
Yes.
We'll bring her on the screen in just a moment so that we can kick off our discussion about breast cancer health and the importance of preventive care. And we just want to remind our viewers that if you have any questions or comments for our special guests and you would like to post them, we're moderating the questions, and of course our special guests can see the questions. So hopefully if you have some thoughts or some feelings about breast cancer awareness or prevention or anything that may be on your mind, not only as females, but also as males, now's the time for you to join in the discussion and ask the questions, because I'm sure Dr. Hampton has some great answers for you. We will go to a commercial break really soon because we have a couple of special things that we want to, of course, acknowledge. First of all, our sponsors, but also, Sister Joella, this is the 22nd anniversary of the publication of the World Whittemore Community Magazine. So that's quite an endeavor. And Brother Edward is going to be with us a little bit later on to say a few words about that.
Yes, ma'am. To God be the glory for all of our beautiful supporters for those 22 years, and we're still growing, and we thank God for it. Thank you, ma'am.
Mm-hmm. Absolutely. So at this time, I'm going to go ahead and bring on Dr. Regina Hampton. Hi, Dr. Hampton. How are you?
I'm good, thank you.
All right. So I know that a lot of you who are watching are probably thinking to yourself, Dr. Hampton, we don't have a Dr. Hampton in Horry County. Well, we don't have a Dr. Hampton in Horry County, but we have a Dr. Hampton who's connected to Horry County. And she is from the Washington, D.C. area. Am I correct?
Yes, that's correct.
All right. Awesome. So why don't you tell our viewing audience a little bit more about yourself?
So I am a breast surgeon and breast health expert. I practice in the Washington, D.C. area, just outside of Washington, D.C. It's an area called Prince George's County. I'm the medical director of the breast center at Doctors Community Hospital, which is now a part of Luminous Health. I'm also the medical director and co-founder of an organization called Breast Care for Washington, which is a mammography screening facility located in Ward 8, which is in Washington, D.C. And then I'm also the co-founder of a store in the D.C. area called Cherry Blossom Intimates, which is a bra and intimates boutique that caters to women of diverse backgrounds, all shapes, all sizes, and specifically focusing on items for women who've gone through breast cancer.
All right. Well, you have quite a list of credentials, and it's wonderful to see a woman of color, and particularly an African American woman, who is so deeply entrenched in this particular sector, and who has the knowledge and the skill set to fight this particular situation, this breast cancer monster that we have been dealing with for so long. But at the same time, as I was talking to some people a few weeks ago, we've come a long way in breast cancer research and breast cancer health and procedures and all. And so, that's a part of what we want to discuss tonight, is the fact that, having breast cancer does not mean that it's a death sentence, and it doesn't mean that you cannot survive. We know a lot of survivors in the Horry County area. I mean, we could start a list right now, right, Sister Joella?
That's exactly it. And
all ages and everything.
Ages,
and so,
Mm-hmm.
And so it's great to have you on tonight. It's actually a blessing. So Dr. Hampton, let's start with that particular concept, the stigma, and why we have to constantly educate the public, especially the African-American community, about breast cancer health.
Yeah, I spend every day trying to figure out why people haven't come to more of the positive sides of breast cancer. It's interesting because, white women, and although there are some differences, white women just seem to take a breast cancer diagnosis a little more positively. I think in our community, there just still is a lot of negativity, a lot of shame surrounding a breast cancer diagnosis. And what I tell people is, look, breast cancer is the most treatable cancer out there. There's some other cancers in other parts of the body that, we're not even a third of the way of all the progress that we have in breast cancer. And, I always say the good news is for a stage 0 or a stage 1 breast cancer, the 5-year survival rates are 100%. 100%.
100%.
Wow.
Yeah. So if we're doing early detection and finding cancers at those early stages, no one should be dying of breast cancer. And even for a stage 2, we're up to about 93%. And even for women who have a stage 3 or stage 4, in many cases, we can downstage them to an earlier stage. And for stage 4, they're never completely cured. We can, get rid of the cancer and turn it into almost like a chronic illness. So there are many women who have stage 4 breast cancer who are still living lives and being fabulous. And so I think that's the good news. And we've got to start talking about good news.
Yeah, absolutely. Because I think that a lot of times, just as soon as someone hears a diagnosis, they think, okay, that's the end of life for me, or, I can't fight this. I can't beat this, because there's so many dynamics that are involved. I'm sure they think about the financial challenge. They, just think about the physical challenge, the emotional and the mental challenge. And, some people don't have a support system to, help them or push them forward. And I know those things are important as well. But, we have to keep sharing the good news. And just like you said, we got to take and your article stated that we got to take the fear out of it. And I think that's a part of the reason why a lot of women, especially in the African-American community, do not talk about it. If they are ever diagnosed with breast cancer, they keep it to themselves. And, Aunt so-and-so or, grandma so-and-so, could be diagnosed with it, and you would never know because they keep it covered up, or they go through the treatment, or maybe even not without telling anyone. So it's really important that people listen.
I've had patients who've come into my office and I say, well, do you have a family history of breast cancer? And they say, well, no, but, my grandma, she always had one breast. And I was like, well, that was breast cancer. Well, no, nobody said breast cancer. Well, guess what? They should have, because nobody has the breast removed unless they've had cancer, or unless we've done it, preventatively to try and prevent someone from breast cancer. And usually we're going to do both breasts, not just one breast. But, we've got to talk in our families. We've got to talk about our health history. And even beyond breast, we need to know who had colon cancer, who had mental illness.
Exactly.
I mean, some of these things are passed along. And if we can know it and talk about it, then we can save the future generations, so that people are more likely to go get those screenings for that mammogram, or go get that screening for that prostate exam, or go get that screening for that colonoscopy, so that we can diagnose something early. And in many cases, we can be preventative. What I say in this day and age is that, cancer, yes, they are bad cells, but we can have good outcomes. And I think, as a community, we've got to start speaking more positively. We've just got to be more positive. If we're not being positive, who is going to be positive?
So
This is true.
May I ask her a question, please? It's regarding, you said when you started out and you saw how women of color were not getting the same kind of care, I guess maybe the emotional care. And that's what gave you the passion to want to step out and begin helping women of color. Can you please go into that a little bit for us?
Yeah, so when I started in the community where I am, I was one of the few female surgeons, and it was mostly male dominated. And not to say that there aren't great male physicians, because there are, but they just didn't treat the women with dignity. They didn't give them the opportunity to have a conversation. It was very paternalistic. This is what we're going to do. And, I just came in and said, this is just not right. And this is not the same care that's being given at the institutions surrounding us. And just because this is a primarily Black county that we live in, and actually very educated, middle to, high class population, it doesn't mean that they don't deserve good treatment just because of the color of their skin. And so I think also on the flip side, we have got to speak up and, be our own advocates and,
That's right.
Not take the first answer that you hear, or, if you're with a physician or a provider that just, it's not a good vibe. You're not getting good juju when you're sitting in the room with that person, or they're not addressing you, they're not looking you in the eye, then you need to fire that doctor and go find someone else. You can fire doctors. It's okay to do.
Yes.
And so you need to be empowered to get the care that you need. I say, listen, sisters, we will shop for that good handbag, those pair of shoes, that cute dress. But we should be as discriminating with somebody who is caring for our most precious commodity, our health.
Yes.
Yeah, you're absolutely right. We can't be afraid to speak up because we know our bodies better than anyone. And if we aren't descriptive and really transparent about what we're feeling, then it's hard for professionals like yourself to make proper diagnosis and to assign proper treatment. And so you're right. And like you said, it's okay to fire your doctor if you feel like you're not getting what you need. Second opinions are warranted a lot of times, but when it comes to this type of thing, you have to really take it into your own hands to seek the kind of help that you need. So I know you were talking about the positive, and of course, we can't talk about the positive without talking about the negative. And what I mean is the triple negative, which you mentioned in your article. And one thing that, as you stated, is shocking, and that's a great word to describe it. Shocking data when it comes down to African-American women is that African-American women have less breast cancer, but die at higher rates than our white counterparts. And I'm sure it's for a lot of the reasons that we've already discussed. And so can you talk about, a little bit more about the disparity and, what we need to do to make sure we're combating those odds?
Yeah, so when we talk about this disparities, as you said, Black women die at a 40% greater rate than white women. And we look over the years, we certainly have decreased death rates from breast cancer for all women. However, it has decreased greater for white women than for Black women. So it's decreased about 30% for white women and only 1 and 2% for Black women. And there are some reasons for that. We do get breast cancer at younger ages. We often get breast cancer under the age of 50, whereas our white counterparts tend to get it over the age of 60. And so when a young woman comes in, she oftentimes is ignored. No one takes the time to find out her family history. No one takes the time to realize that these women can get breast cancer at younger ages, and we should take every complaint seriously. Right. And then the other thing that compounds it is the triple negative breast cancer that tends to occur in these younger women. So triple negative breast cancer is a tumor that is not responsive to hormones. So we'll switch and talk about hormone positive tumors. So for women that have a hormone positive tumor, this means that their tumors like to take in the natural estrogen and progesterone that we all have that makes us women. And we have a medicine that can block the tumor from getting any more estrogen. And once we've treated a woman with hormone positive cancer, given whether that be surgery, plus minus chemotherapy, plus minus radiation, we're going to put her on a pill that's going to be a hormone blocker. It's going to block any new tumor cells that decide they want to grow. It's not going to give them access to our wonderful hormones. So those cells will not grow, or they have a lower likelihood of growing. For triple negative breast cancers, those patients, they don't have that hormone receptor on the surface. So it doesn't care if we have estrogen or progesterone in our bodies. It's just doing its own thing. And those tumors are not responsive to the hormone type of medicine. So those patients are going to get surgery plus minus, well, they're all going to get chemotherapy, and we can talk about that shortly, plus minus radiation. And then we don't have a maintenance pill like we do for the hormone positive patients that we can put them on for the next 5 years. It's just monitoring them and watching them and making sure that they don't have a recurrence. Now, and again, good news is that we figured out the most important treatment for the triple negative breast cancer patient is chemotherapy. And because we know that, we now give that medication up front. And so my conversation with my patients is, look, the most important treatment you need is chemotherapy. Whether I give it to you before surgery or after surgery, you're going to need chemotherapy. So let's give you the benefit of giving it to you before surgery. It's going to do a couple things. A, if the cancer is found to be just localized to the breast, what we can see, if there are any cells that we can't see that have started traveling elsewhere, we can wipe those out before those have a chance to do anything, before we even do the surgery. Then we can also downsize the tumor before we even go to do surgery. And that allows us to really see how the tumor is going to react. And that can be important because if the tumor is not reacting, we can change course, switch up medications so that we can try and get the response that we need to get. The good thing about triple negative tumors, when they're treated with chemotherapy before surgery, they have about a 40% risk of completely disappearing before we even do surgery. So I just treated my office manager. We just diagnosed her earlier this year. She got her chemotherapy up front. I did an exam after she finished. I was like, yeah, I think I feel a little something. It's definitely smaller. When they evaluated the area and the tissue that I took out, there was not even one cancer cell. She had completely responded to the chemotherapy. Yeah. So in that case, I think she's going to have a great long-term prognosis because we wiped out the tumor before we even took it out.
And I think too, you've mentioned chemotherapy, you've mentioned radiation. I think people hear those terms in, social circles or whatever, and it scares them. That puts the fear into them as well. So what is the difference between chemo and radiation?
So if you think chemotherapy is liquid medicine and radiation are x-rays. So chemotherapy, we're going to most commonly put into an IV form. It's going to get into the bloodstream, travel throughout the body, and kill off cancer cells that are in the breast or have left the breast. It is because it's traveling around the whole body. That is the reason why you will see more side effects with chemotherapy, but the side effects are temporary. The most common is hair loss. I know how we all feel about our hair and our hair, but what I tell folks is, look, half y'all out there wearing wigs anyway, so we don't know if that's real hair or not.
That's true.
So what's the difference?
That's true. Even if we have beautiful hair like yours, we'll throw a wig or a weave or something on it. You're right.
Thank you. So what are we doing? Okay, put a wig on and keep it moving. Although a lot of women look great bald. I know my office manager, she just said, forget it. And she just looks beautiful. So switching over to radiation, radiation is using x-rays, and radiation is usually done after surgery. And what it does is it kills off any cells that might be left behind that we don't know are there. And so we certainly will take out everything we know is there, but could there be 1 or 2 cells left? There could be. And so the radiation is sort of the cleanup. It comes behind and kills off those cells.
All right. Well, we have a comment that I want to put on the screen, and I just happen to know this gentleman here who is actually watching from Hawaii. And so he says sometimes the problem is also the patient, tough dealing with stubborn people that are in denial. And that goes, it's a good segue into a portion of your article where you talk about the fact that African-American women are not doing self-breast exams, or not getting the mammograms as recommended. So speak on that a little bit.
Yeah, I say, we got the word on the street. Word on the street said, we shouldn't be getting mammograms. Well, what degree do the people on the street have?
Right. Right. Mm-hmm.
Word on the street, these same folks talking about the vaccine, which I'm sure is another conversation altogether. But, it's people using these rumors, people, kind of using the sort of the folks who may have not done well. And certainly, yes, there have been people who have not done well with their treatment. But why does that have to be the first story that we present with? I can't tell you the number of patients that I have that are newly diagnosed, and they're sharing, and they're, well, girl, so-and-so had chemo, and you know what that did to her. And it's like, thanks, just got diagnosed. Can you bring me something positive?
Right.
It's just, we've got to just bring positivity. People are like, well, I don't want to say the C word. And I purposely make all my patients say cancer when they're diagnosed. I think it's important. And I think it helps get them over this hurdle of, okay, you said it. You didn't turn into a frog. You did, you're okay. And
you're meeting
so
head on at that point.
That is an important part of the process. Is people are like, well, we're not going to say the C word. We're not. Well, why not? It's just a word. And we need to deal with it. But I think it's just sort of, we've got to let go some of those, dare I say, old myths, old wives and husband tales. I'm not going to put it all on the wives, but old husband tales that keep floating around. I mean, I still get people who ask me, is it safe for you to do surgery? I heard when you open me up, the cancer's going to spread. And it's like, okay, folks, let's think about that comment for a minute. First of all, I probably have another job because somebody would have me in some shackles and an orange jumpsuit because I've been knowingly causing harm to people. And there's millions of surgeries done throughout the world. And I think if it were that dangerous, nobody would get surgery for anything. So it's, we've got to let a lot of those things go. And I realize there's a history that comes along with them, but let's learn the history and let's turn it into power and use it to empower and to encourage each other.
Absolutely.
If you had a chance to work with, I guess, maybe younger females, or, that's where their minds are so opened up. And just like you were saying about a generation who hates to hear the C word. But when we start working with our youth, and they want to know more about that. So that is why, it's a blessing to have you on here, because it gives us ideas that even in our summer job program that Sister April and, a staff is involved with, we're going to start bringing in medical terminology to make them go and look up these terms and understand a little bit more about their health. Because as you said, we're getting younger, our females are getting younger in terms of being diagnosed with breast cancer. And we need to let them know that they still have a life to live in terms of getting, over that. So thank you again for bringing that up about the old wives' tale. We just have to have patience with our people. As the brother said, sometimes it's the patient, but we just have to have patience with our people. Thank you.
Absolutely.
I tell people, at the next gathering, I know we haven't been able to do our normal gatherings like we have in the past 18 months or so, but, at your next gathering, take index cards and people write down what you know about health history, because and who, it's important to know who had what and the age, because name a disease, we get it younger. Prostate cancer, colon cancer, lung cancer, all of these things we tend to get at younger ages. And so we need to know these things so that we can, again, help each other, help the younger generation so that they know what to look out for.
Dr. Hampton, I think everyone has a different perspective of what is young and what is not so young. And is there a range where you consider someone to be still in that young range, or, I guess more on the elderly side when it comes down to how you look at medical statistics and things of that nature?
Yeah, I think we still use, kind of the Medicare guidelines using 65 as the cutoff, although, these ladies in their 70s are working it, and some of them are healthier than the younger women and keeping themselves in shape. So, I think in the medical community, we have to really redefine age. And the good thing is we're really now looking at personalized care and not forget the age, forget what the patient looks like, what's going on with their body, and let's make decisions that accommodate that person. And even with breast cancer treatments, we've really personalized treatments. I could bring 10 women in who've all had a little bit different treatment. And so we make recommendations based on what's going on with that woman and what her tumor is telling us to do.
So what is a good age for women to start annual mammograms?
So we recommend starting at age 40 if you don't have a family history. And this is where, again, family history makes a difference, because if there were young women in your family who have breast cancer 45 years or younger, then we would want to start 10 years earlier doing at least a risk assessment on those women. And in fact, one of the major societies, the American College of Radiology, has deemed Black and Jewish women as at a higher risk, because Jewish women tend to get breast cancer at younger ages as well, and they tend to be mutation carriers. So with us being what they consider high risk, they recommend that all African American women should get a risk assessment, meaning you go in, find a breast specialist and or a genetic counselor. We're going to have an in-depth conversation, dive into your family history, find out different things about your own history. And then we may say, okay, 30-year-old woman, we probably should start screening you now, or maybe we're going to just follow you closely with clinical breast exams and have you come in every year, every 6 months, so that we can stay on top of it. Certainly, if there are women who have family history, and I know there's family history, I actually will start doing mammograms in those younger women.
Okay. All right. So before we go into the second part of the show, there's some great things we're going to get into after the commercial break. The importance of participating in clinical trials. I definitely want you to get into that. And then, some options other than chemo for treatment, how the technology has improved. And then, of course, any other information that you feel is going to be helpful as everyone tries to educate themselves more about the importance of breast cancer awareness and also breast health. So we're going to go to a commercial break, give you a chance to get some water, and then we will be right back.
Thank you, Doc. Okay.
Brother Edward, how are you?
Look at. I told I told Kendrick I was going to dress the same color that you have.
You did it. We're coordinated.
He said it was okay.
All right, awesome. How are you this evening?
Good, very well. What about you? I'm just going to be here briefly, just to just go over something and let the audience know about the celebration. Okay, this 22nd year of celebration, and just want to let you know that. Can you put that up, Dave? About oh, did you?
Go ahead and talk, Brother Edward.
Yeah, okay. Something to bounce off of. Yeah, this year we're celebrating our 22 years, celebrating 20 years of publishing, and we just wanted to really express our appreciation, gratitude, and everything, and just say briefly about a little history that was founded back in 1999 by me and my wife, Joe, and formerly was called the Whittemore. We started off with like the Whittemore newsletter, okay, back in 1999. So we're striving to present our readers with the diverse economic, education, and political issues, local, regional, national, and international. Okay, so it culminated into the World Community Magazine, starting off with in 1999 with the Whittemore newsletter. We haven't left the Whittemore theme yet. I don't think we're going to leave that. But now that we've grown, we got to keep up with growth. You just don't stay stagnated. So, and a lot of things have happened. So we wanted to really thank our viewers, thank all the people that have supported us for these 22 years, and I'm really humble. I'm grateful myself, and so first of all, I should thank Dr. Hampton for coming on here today. Okay, really appreciate her coming on. So if you allow me to just call the names of some people who no longer with us, but started off with us and who were very, very integral in providing information and working on the staff. And they've since gone and no longer with us. So I'll start with Dr. Hughes, who was our medical correspondent. Julia Ewell, she was the first treasurer. Mitchell Falk has assisted us greatly. Dennis Lattimore then took over the medical correspondent issue. Ms. Elka Sendab, Ms. Gwen Manigo, who we just recently lost. I think it was a couple of months ago. Ms. Alberta Myers Mazik, obviously recently lost also. Ms. Sylvia Conwell, and Mr. Herman McNeil, and of course Ms. Leonelle McQueen, better known as Nora, they call her. We just lost her about a year ago or less. So we want to pay homage to them and let the public know how much we really did appreciate them. We're sorry for them, really for their families to for this loss. Okay, and it's a huge loss to us. Okay, but now we'd like to thank the following former staff members who are still in the area, but they're just former. They're still working in our local communities, not necessarily for the magazine, but they're working and doing community achievements and community, chores. I'd use the word chores, but things that add value to the community. Miss Edna Bellamy DeWitt, Pamela Jones over there on Fifth Avenue, Mr. Craig Conwell, I think he's in Columbia. And finally, we just want to thank our hardworking staff, the present staff we have today. We call them our staff. I mean, they contribute in many, many different ways. And we owe them a gratitude for making sure that the magazine comes up and present the quality that we have. Okay, either in digital edition, the social, and other news and media otherwise. So I'll start with Ms. Jennifer Flowers Falk. She's the treasurer, as our treasurer. Of course, Ms. April Garner. You can get behind that mask, Ms. April Garner. She's been my co-host since I think 2011, right, April? Okay. And Ms. Marjorie McIver, Vernell McDowell, Judy Steele, Lee Moultrie of Charleston, South Carolina. Ms. Betty Goss right there at Bucksport. Sandra Gora in the Longs area. Mary Cookie Goins, Myrtle Beach. Ms. Caitlin Barker of the Bucksport area with the James Frazier Community Center. Ms. Clara Chadman Brown. She is a jewel. Okay. This year they were celebrating their 70th high school reunion. That was something. Wow. And also Miss Elfrida Funny. She sometimes periodically contribute photos that we were otherwise couldn't get. So we want to thank these people, and along with anybody else if we left off any, I doubt it, but we just want to show our gratitude. And while we're talking about breast cancer, April and Dr. Hampton, if I want to touch base and let the public know that we're still delving with this issue of prostate cancer. And back in December of 2020, I believe we had on this program a topic was called the fear of cancer screening for prostate and other cancers. And I think at that time we did include breast cancer, but it was all men, so we didn't venture too far on there. But we mentioned it as one of the cancers that people fear screening. So just want to throw that out. And one just a footnote. This old wives' tales stuff. I mean, old men. What you call it? Old men tales. Is that what what Dr. Hampton said? So, Dr. Hampton, let's keep it as old wives' tale. Let's do that. I'm going to depart now after I said that.
Yeah, you need to go. You know what, Brother Edward, it's interesting that you mentioned, the prostate cancer screenings and other screenings. But as I said at the top of the show, and I know Dr. Hampton will co-sign this, men get breast cancer too.
I know. Yeah, I know. Absolutely. Yeah. One famous person, Richard Roundtree, was one of the most noted ones that had it. I mean, it was treated, I guess, and I don't know if he still has it, but he had it. That's been 5 or 10 years ago, I believe. But hopefully he's doing well. But anyway, I know you all want to get back to these very important topics. Like the other option other than chemotherapy. I know that's the one I really want to hear, because that obviously is synonymous with the prostate issues, where they have different options like that of chemotherapy now that they've come up with. So I'll excuse myself.
All right.
Okay.
All right. We'll let you make the transition, and I'll continue the conversation until Sister Joella gets back. Okay.
Right. Now you can go with the commercial if you like, if you have it anymore.
I think we're probably out, but that's okay. I got you. Thank you, Brother Edward, and congratulations on 22 years of publishing.
Thank you, and thank everybody who helped us.
So, Dr. Hampton, first of all, welcome back, and I hope you had a chance to kind of refresh and get ready for the last portion of the show. So, as we mentioned going into the commercial break, just talking a little bit more about participating in clinical trials and why it's important for African American women to do so. And what's interesting, when I saw that particular talking point, a colleague of mine at one of the hospitals in North Carolina was talking about the fact that there's a lot of clinical trials out there that African Americans in general just do not participate in. So they can't generate enough data on our populations or populations related to people of color. And it's important for us to make sure we're participating in clinical trials. Again, I think there's a stigma behind it. There's a lot of fear. People think, oh, I don't want to be an experiment, that kind of thing. And so I guess you just have to do your research and know which clinical trials are legit and which aren't, or maybe even consult with your doctors to find out more about them. But talk a little bit about participating in clinical trials and why it's important for our population.
Yeah, so, clinical trials are important, and that's really the reason why we have so many successes in, name anything, medications, over-the-counter medicines, those went through clinical trials. The reason why we're doing so well with breast cancer, all of those treatments went through clinical trials. It's not like somebody just sort of, put their finger up and said, hey, it's going south. That's the treatment we're going to use. Mm-hmm. It really took people who sacrificed and said, I want to really be a part. And I think it's so important that African Americans do become a part of clinical trials because, again, our cancers are different. And so with our cancers being different, how are we going to get the answers if we're not a part? And, I think we've got to, yes, recognize where we came from. We've got to recognize our history, but we also got to recognize because of all that is why the whole process of clinical trials has changed. The whole process of even how we deliver medical care has changed. I can't just take somebody to surgery against their will. I have to talk to them. What are the risks? What are the benefits? What are the pros? What are the cons? And then they have to sign a paper that says it's okay for Dr. Hampton to do this surgery. And I can only do whatever is on that piece of paper. So all of that came about because of, some of the things that happened in the past. And so, I look at, granted, those things were horrific and they probably shouldn't have happened. It's the reason why we've come so far today. And so, clinical trials take on so many different forms. Not all clinical trials mean that we're going to give you a medicine or a treatment and see what happens. Some of them are what we call observational. So I have a colleague in the DC area. She's doing an observational trial on mammograms. It's 3D mammogram versus 2D mammogram. So you got to get your mammogram anyway. And all she wants to do is follow you, ask you a couple questions every year. I even enrolled in a study called the Wisdom Study, where, again, it has to do with mammograms. Right. And I got to get a mammogram anyway. So I have to go. I have to answer some questions. I don't have to take any medicine. I'm just doing the same mammogram that I'm doing. But I think it is important that we do get into these treatment trials because, especially when it comes to triple negative breast cancer, I don't think we're going to find the answer unless we become a part of the trials. And so, I think we've got to realize, things have changed and we're just in a different time. And we got to kind of remember the past, but we got to let go of the past in some respects, because I think it holds us back. And I think it's really holding us as African Americans back from really being able to find the treatments that work for us.
Absolutely. We were talking, and Brother Edward said he was very interested in hearing this part, but the other options or the options other than chemo when it comes down to treatment, talk a little bit about that and the technology that's available.
Yeah. So, as we talked about, chemotherapy is just liquid medicine. We have a newer test that we can use to see if anyone even needs to get chemotherapy. Not everybody needs chemotherapy. Certainly, if you're triple negative, that's the most important treatment that we have. You're not going to get out of chemotherapy unless you're just refusing treatment. But if you have a tumor that's hormone responsive, if it's estrogen and or progesterone positive, then we can take your cells, put it through a test, and the test will tell us, will you benefit from chemotherapy or not? And if you're not going to benefit, we're not going to recommend it. And so that's one of the newer technologies that we have out there. Again, unfortunately, triple negative chemotherapy is it. And I think that's why we've got to get in clinical trials. So maybe somebody can discover a pill for the triple negative patients.
Sister Joella, do you have any comments?
Yes, ma'am. I'm just, so humbled to hear all of this information that's coming forward. And I just wanted you to talk about your breast cancer awareness Day of Giving Can you tell us how does that work? Because the magazine really likes to reach out and help, programs that are benefiting us. And if you could just share that with us, we would certainly appreciate it. Okay.
So that's through my nonprofit, Breast Care for Washington. And so Breast Care for Washington actually sits in a community, and it was so important for us to be in the community. We sit in a community that has a very high mortality rate from breast cancer, primarily African American. And so we provide mammograms, whether women can afford them or not. So we don't turn anyone away. And so we provide 3D mammograms. We do breast sonogram. If they need a biopsy, we will do the biopsy. And then if a diagnosis is made, we've partnered with several other hospitals and breast centers. And so we will navigate those patients to the care that they need in order to get treated for their breast cancer. And so we use that money, the donated dollars, to help provide mammograms and seek out services for those women.
Would you please give Sister April that website where they can go, where everyone can go to and take a look at what you're doing? Because I was just blown away when you had that party for women. I think it was before the COVID, and everyone dressed up and had the mask on. And it was just a beautiful testimony to what the women in that particular part of DC really appreciated doing, and you're reaching out to them, and they just had a ball. They really had a ball.
Yeah, it's breastcaredc.org. It's breastcareforwashington.org. But thank you so much.
Okay, yes, ma'am. And please thank your beautiful mother too for us, because she arranged all of this, and she's always pleasant. And Sister April and I just enjoy just listening. So thank you again for all that you have given us tonight, all this knowledge and such. Okay.
Oh, thank you. Thank you. My pleasure. I have a passion. I want to make sure that we as Black women, that we can turn those statistics around, because I think we can do it. But we've got to realize we've got the power to do it. We can't wait for anybody else to do it. We've got to do it ourselves.
Absolutely. Right. Well, we've definitely received a lot of great information. And, the one thing that we want people to really understand, young and old alike, men, women, what have you, again, breast cancer diagnosis does not mean you will not survive. It means that you have a journey ahead of you that is very manageable, and with the right treatment, the right care, you can have a very positive outcome. As Dr. Hampton said, we've talked about being positive through these types of crisis or challenges in our lives. And there was one other thing that you mentioned in your article that I think would be definitely a good point to drive home as well. Early detection means that your survival rates are higher. Am I correct?
Absolutely.
All
absolutely. Right. So getting those mammograms, and, I know with COVID, all of us have fallen off our schedule, me included. I just went in and got mine. I'm back on schedule, but, realize again, as health providers and our staff, we don't want to get COVID any more than you do. So we're taking all the precautions on the health provider side to make sure that we're making it safe for people to come back in. Unfortunately, we're seeing a lot more later stage cancers, because of the pandemic, because things were closed down. But we really want to drive home the fact we want everybody to get back on schedule. We're making sure that we're keeping you safe. And so do what you need to do, make that appointment, grab a friend, grab a sister, y'all come together and make sure that you get back on track with those mammograms.
And when we were talking about the technology a little earlier, I know that the mobile mammograms are, something that we see a lot in our communities, where you have the mammogram trailers that are going around to communities or to certain, corporate places that are in high traffic areas, and they're able to do mammograms there on the spot. And I also like the new 3D mammograms they have, because, I'm busty. And so, I always question whether or not the, just the regular mammograms would suffice as far as detecting anything, within my breast tissue. And I really appreciated having the 3D mammogram because I felt like, okay, this is probably able to take some images and scan for things that probably wouldn't be detected with a regular type of mammogram. So, quickly talk about the fact that, now there's almost no excuse. You have mobile mammograms, you have 3D mammograms, you have a lot that's offered now in the community.
Yeah, and also before I touch on the mammograms, there's federal dollars in all 50 states that will cover mammograms for women who are not insured or underinsured. So it's the Breast and Cervical Cancer Early Detection Program. It's a national program. Every state has it. They may name it a little bit differently, but if you go to the CDC website, you can look it up and find that as a resource. So again, everyone should be able to get a mammogram. When we talk about 3D mammograms, which is a form of digital mammogram, what it does is it is taking a digital image, but it's also taking images through the breast 1 millimeter apart. So it's almost like peeling away layers of an onion. So when we look at it on our side on the screen, it's like we're going through these onion layers. And what we may not see just looking on the outside, once you peel away the layers, you may see something on the inside that you may need to address. I also think breast self-awareness is important. I think, we live with ourselves every day. We need to know what's going on our breasts. We need to check our breasts once a month. I still advocate checking once a month. Do it in the shower. You're in the shower where you're putting lotion on. That's considered checking your breasts. So just take a little extra time to just make sure that you're covering all the tissue. Sometimes you may have to push a little bit deeper and know what your normal is so that if something ever feels different, you'll know to get that checked out. And, go see your doctor. Your doctor's offices are open. We are here to serve no matter where you live. We're trying to keep you safe. I worked through the pandemic in the intensive care unit, helping my colleagues when they shut down, all the elective outpatient procedures and office visits. And I can tell you it wasn't pretty.
Right.
But, we're doing everything we can. Like, I don't want my staff to get sick. They're valuable. I need them. So in fact, I just got my booster shot.
Awesome.
Got my flu shot today. So
you're ready to go.
I'm feeling good and ready and protected. So, again, we're trying to keep everybody safe and we want everybody to get back to living life.
Yes, absolutely. It's time. It's long overdue. I can't wait till we can get to not wearing masks. That's like on my Christmas list. But it takes everybody. Everybody has to do their part. So, well, Dr. Hampton, thank you so much for being with us tonight. We really appreciated all the wonderful information. And I just want to thank our viewers. We had a lot of viewers this evening. And of course, we always have a brave few who want to comment or to say something, questions or whatever during the broadcast. And so just would like, here we have Reverend Jerry Falk. Thank you so much for watching. And he sends some kudos to you as well. And Janice Keith, thank you so much, Janice, for watching. Priscilla Fuller, Priscilla's a regular. Thank you for watching. And of course, my cousin John F. Henry, all the way from Hawaii. We appreciate you watching tonight, cousin. Thank you so much. Share the good news across the water, okay? Exactly. So thank you all very much for being with us this evening, and all of the other viewers who chose not to comment. We know you're watching. Please take this information to heart. If it applies to you, that's wonderful. And if it doesn't, well, then share the good news with someone else. And we really do appreciate you being here tonight. So thank you, Dr. Hampton.
Thank you. God bless you. Thank you. We'll be in touch. Okay.
All right. Stay well. Stay safe, everyone. Have a good week.
You too. Take care, Sister April. Good to see you. Always.
You do the same. You do the same. We'll see you soon. Next Monday, 7 p.m. Same time, same back channel every week.
Next Monday, Sister April.
Yes.
Yes, ma'am. Would you please? We're going to have on the show next Monday a local candidate, Miss Amanda Butler, who's running for city council. And we want to have you to tune in because we're going to be asking questions. We're going to be sharing things about what she wants to do in terms of helping the community. And she has a story to tell as well about her mother in the fight with cancer. So again, this was like a prelude to what we are trying to do for the community. So thank you again. God bless you, and we'll be in touch then.
All right, sounds
All right.
good. All right, City Council candidate Amanda Butler next week
Yes.
at 7 p.m.
That's
Please
right.
join us. And again, everyone have a beautiful week.
You too. Take care now.
Thank you for watching the World Community Magazine's Hour of Power Live on Facebook with your host Edward McQueen and April Garner.